called them up, but I thought I was giving. Anyway.
So which is
Just watch my cord down. So. That's a pointer. It's bright enough. I don't know.
where am I supposed to stand?
You were supposed to stand right over a little bit more.
Say,
There.
do you want me to hang your arm back up?
Huh?
Here, the voice.
No, it's fine. It's fine. You're good to go.
All right, you guys ready to start?
Yep.
Okay.
Yes.
I'm George Young. For all of you that don't know me, I'm one of the rehab doctors. We're called Physical Medicine and Rehabilitation, and then I subspecialized in pain medicine. So I welcome you. Thank you for coming out today. Hopefully you all weathered the storm okay last night. And welcome to everybody watching at home. And today what we're going to be talking about is sciatica. So really I'm going to try to give you a better overview of really what is sciatica, what are the causes of it, how we diagnose it, and some of the treatment options we have available for you. So the goals of today's lecture are to go over some of the common terminology that you hear in the community, how we classify pain, and epidemiology is the statistics, how many people does this affect, how long does it take to get better. Sometimes knowing the basic anatomy helps you get a better understanding of what causes the pain. So I'm going to go over basic anatomy, what testing that we use to diagnose you, and then also the treatment options available, okay? So, common terminology. So what is sciatica? Well, sciatica is Latin for leg pain, or pain in the distribution of the sciatic nerve. So the sciatic nerve essentially runs down the back of the leg and into the front leg and into the foot. That's a generic term. It really doesn't, it's a symptom more so than a diagnosis, okay? So most of the time, sciatica is related to a nerve that's being pinched in the spine, and it really has nothing to do with the sciatic nerve at all. Very, very occasionally, maybe less than 1% or 0.1%, will it actually be related to something wrong with the sciatic nerve, okay? The correct terminology for 99% of sciatica episodes is something called a lumbar radiculopathy. So essentially what that is nerve pain coming from a pinched nerve in the back, okay? So everybody comes in and says, oh, I have a herniated or ruptured disc. Well, what does that exactly mean? Well, the disc is sort of like a jelly donut. There's a fibrous capsule on the outside, and then there's a jelly, a soft cushion on the inside. And what happens is that jelly, from pressure, breaks open the outer capsule and squirts out and starts to press on something or leaks inflammatory markers on the nerve. And that's really what's causing the discomfort, okay?
Can I ask you a question?
Sure.
Can that ever rejuvenate itself? Do you know what I mean? Like
usually once the disc is injured, it's injured forever.
It doesn't like regrow over time, or it doesn't.
Discs can shrink down when they're herniated, and then they sort of scar over, but they're never normal again.
It's not ever going to grow. It's not going to get it puffed up again.
Correct. Yeah, once it kind of like gets injured, it slowly kind of degenerates over time. Okay. And I mean, there is some newer technology stuff that's going on, but we can talk about that after the treatment options. Okay. Then a lot of people have heard the term spinal stenosis. What is spinal stenosis? Well, spinal stenosis is a degenerative condition most of the time that causes thickening of the spinal structure. So there's discs, there's ligaments, there's joints of your spine that essentially once you're done growing as a young adult, your spinal canal is like a tube where all of your nerves in your spinal cord is. And once those arthritic changes start to occur, it narrows that tube and it becomes narrowed and thin, and it starts to squeeze these structures. So the majority of the time when people have spinal stenosis, they have pain in their legs when they're standing and walking. It usually gets better with rest, okay? So, and then what's a scoliosis? Well, everybody has heard, scoliosis screening in their kids in school. Well, what does that mean? Well, it's an S-shaped curvature of the spine when you're looking at somebody from the front or the back. It's an S-shaped curvature. The majority of the time it happens in adolescence when people go through their rapid growth spurts. That's why it's screened for in schools, and that's where we can identify the majority of the cases. It happens in neuromuscular disorders, but really, that's something that's beyond the scope of this lecture. And then a lot of people say, oh, I got a slip disc in the past. Well, a slip disc is essentially a disc herniation. So it's kind of used interchangeably. It's just kind of a slang word for a disc herniation, okay? Now, how do we classify pain? Pain in any fashion, acute pain is pain that lasts 4 weeks or less, okay? Subacute pain is anywhere between 1 month and 3 months, and then chronic pain is pain that lasts for greater than 3 months. So it's pretty basic. That's what pain is. 4 weeks or a month. Okay? And then 4 to 12 weeks is subacute, and then chronic is 12 weeks, which is about 3 months or so. Okay? Now, how many people are affected by sciatica? Well, every single year, it depends what study you look at, but between 15 and 40% of people are affected each year by an episode of sciatica, okay? Or pain from the back that runs down the leg. I'm sorry, in their lifetime. That's 15 to 40% in their lifetime, looking at epidemiological studies. Annual risk is 2 to 3%. So about 2 to 3% of the population every year suffers from an episode of sciatica. I apologize for that. And what is the most common spinal level that is affected? The L4-5 level. Then it's followed by the L5-S1 level, and then the L3-4, L2-3, and then the L1-2 is the least common level that's affected by a disc herniation that's irritating a nerve. Okay? Now, what's the prognosis? Well, people talk to me about how quick am I going to get better, doc? When is this going to be done? Well, when you're talking about nerve pain, it takes a little bit longer than muscular pain or just low back pain. Low back pain, about a half of people will get better within a week. That's pretty good. 90% of people are better within 12 weeks. Look at the difference when you have nerve pain involved, when there's a nerve being irritated and causing sciatica. Only 50% will get better within a month, and only 70% or 75% will get better in half a year, 6 months. So it takes a longer time to recover, and less people recover from episodes of sciatica. Okay?
Excuse me, doctor. Back to that one. What was the cause? Do we know the cause of the first part, the low back pain?
Well, low back pain is just people that have back pain that doesn't go down the leg.
Okay,
So people bend over, lift if something in their back hurts them. It's not involving that nerve pain component. So what I'm trying to do is compare, when people come with back pain, it's usually better prognosis than people that come in with nerve pain down the leg or it's the sciatica episode. Yeah, so there's a huge difference in prognosis when people come in with these different complaints, okay? So what are your risk factors for developing back pain and then also developing a lumbar radiculopathy or sciatica? Well, anybody that does a lot of heavy bending and lifting is at risk of having disc problems in their back and therefore having disc herniations and sciatica. People that smoke, higher risk of disc disease in their back, also having sciatica. Now, chronic pain, psych, emotional, and personality issues are more for those chronic pain patients that don't get better. It's not really a risk factor for acute pain. That's really not an issue, okay? This is more of a risk factor for chronic pain. Obesity is a risk factor for disc disease and back pain. Spinal deformities like the scoliosis I was talking about, or some sort of trauma that caused a fracture, puts you at risk for the discs to herniate and cause an episode of sciatica. We've been finding out more and more that there is a genetic predisposition to this, okay? So if mom and dad, brothers and sisters suffer from back problems and disc problems, you're probably going to be at a higher incidence. And then peripheral vascular disease, people that have clogged arteries in their legs, vein problems, heart problems. We think that it has to do with if the vascular supply is affected in your extremities, the vascular supply is affected to the discs, they become friable, they break easier, and they herniate easier. So that's kind of the philosophy behind that. Any questions on that?
Diabetes?
Diabetes is not a risk factor for disc herniations.
Just wonder.
Yep.
Doctor, I see obesity where that fits. The psychiatric, emotional, and personality, which comes first? Are we saying the person with psychiatric and emotional problems is more prone to sciatica?
More prone to
or
chronic.
The sciatica
More
causes.
No. I shouldn't put that in the slide. It's more risk factors for chronic pain from an episode of sciatica. So
As
something that lasts longer.
Chronic pain, or
it's just a risk factor for chronic pain in general. people that have a hard time dealing with pain sometimes don't have as good of a job coping with it long term. Therefore, it turns into more of a chronic pain syndrome.
Oh, I got you.
But not really, that has nothing to do with the actual disc herniation risk. Okay. Just getting over the episode, sometimes turning it into a chronic pain syndrome, that can be a risk factor. Okay.
Is a sitting job a risk factor if you have to sit 8-10 hours?
No.
No?
No.
Okay.
It's a risk factor for having a hard time dealing with sciatica because that's an uncomfortable position, but not its cause of a disc herniation.
Okay.
Okay. Now, what are the red flags? Red flags are anything that we hear from patients that will require us to look into it very urgently, or even send people to the hospital for immediate evaluation. So one of the red flags is age. Somebody less than 20 or over the age of 50, we're a little bit more prone to look into things because bad things can happen in those age ranges that we don't want to miss. Pain that's worse at night, you shouldn't be kept awake by pain, okay? That's something that's usually a red flag. We need to look at it and make sure that we're not missing something that's aggressive. A history of trauma, that's really to rule out fracture. History of cancer, we want to make sure that you don't have any cancer in your bones that's causing this pain or any cancer that could be pressing on a nerve. Constitutional symptoms. I'm losing weight for no reason, doc. I don't know why I'm losing weight. I don't know why I don't have an appetite. I don't know why I'm tired all day. These are the things that we really look into and make sure that there's no, a lot of times cancer or something that's aggressive going on in the body that's causing your symptoms. Fevers, chills, night sweats. That's sometimes infection, or it also can be a sign of some sort of cancer that's driving these kind of symptoms at nighttime. And pain that just is not getting better from anything. Well, we need to figure out what's going on so we can help you. Now, caudal equina syndrome it's almost an emergency where we need to take you into the hospital, make sure that there's nothing pressing on the nerves, and we need to decompress you urgently. So what does that mean? 3 symptoms: saddle anesthesia. So imagine if you're sitting on a horse, anywhere where that horse saddle is touching you is the saddle region. So, down in the area where you can't feel yourself wipe after you go to the bathroom, the inside of the thighs, the buttocks, that's really the areas that should not be numb from a back issue. If it is, that's a major problem. Okay? If people have bowel or bladder incontinence, bad. We don't like that. We don't want it to become permanent. We need to let those nerves breathe and decompress you urgently. And also, people that just have their legs are weak, they can't stand, they're clumsy, they're falling. These are all the things that we really need to look into to make sure that you don't need an urgent decompression, okay? So this is one of the few surgical emergencies when it's related to the spine. Now, what's the anatomy? The anatomy of the lumbar spine is 5 vertebrae. In between each bone or the vertebra is an intervertebral disc. The spinal cord doesn't really run down the entire spine. It ends at around the L1 or the L2 level based on your anatomy. Okay, so most disc herniations will never affect your spinal cord, which is a good thing. Okay, nerves. The nerves come out of your back and they go down to your legs. They go into your pelvis. And then you have the soft tissues, which is muscles, ligaments, and all the fascia, which is the small connective tissue that keeps all the layers of our muscles together. Okay, all of these things can cause pain. So this is a description or a diagram of the spine. Right here is your vertebra, the bony block. The white in between is your disc. This yellow piece is a nerve coming out of your back, and essentially these nerves form together to go down into your legs. They give you your strength and your feeling in your legs. And then you have the white things are the ligaments that hold the spine together and keep it strong so that it doesn't slip and doesn't move around. And then you have joints of the spine here called your facet joints right there. So that's the anatomy. Any questions on the anatomy? Okay. And then in between this bony layer is your spinal column. That's where your spinal cord ends, right around here. And then all your nerves float down in your spinal fluid. And then they come out of those little nerve tunnels to go into your legs. Now this is a picture of a herniated disc. So, as I said before, it's like a jelly donut. You have the outside, which is a fibrous capsule. And then on the inside, you have this gel-like substance. And essentially what happens is pressure on the inside makes this gel rip the capsule. and then the disc herniates out, and then the nerve runs through this bony canal and gets pinched by that disc, causing the sensation and the pain to run down your leg. Position that's most uncomfortable with somebody who has an acute disc herniation is sitting. They're usually better standing or lying flat. Now, if somebody has spinal stenosis, all this area becomes thick, and essentially this big space where all the nerves run becomes very narrowed. And essentially when you stand, that puts pressure on all those nerves. And essentially most people have just leg tiredness, fatigue when they're standing and walking. And doc, I need to lean on a cart when I'm in the shopping mall, or I need to sit down and then my leg pain will go away. Now, a lot of people ask me, well, what's the difference between a disc bulge, a disc herniation? People have all these different terminology that they hear or they read on the radiology reports. Well, a disc bulge is this top one. Essentially, it's a degenerative change of the disc. So essentially, just a little piece of the disc is just pushing that capsule out and it's bulging out. Most of the time, disc bulges are just a degenerative change and arthritic changes of your disc in your spine.
Because you get older, or
correct.
Or injury?
Yeah, it could just be a mild injury. Most of the time, disc bulges don't cause sciatica, okay? Oh, sorry. A prolapse is another word that we use for herniation, okay? So the prolapse is when it's a little bit more severity. It's more compressive. So that disc herniation is out and it's pressing on that. It's pressing on that nerve root, okay? But usually it's contained in the ligament. And then the extrusion is essentially when it bursts open and then a little piece of the disc is kind of in the spinal canal, okay? The good thing about this extrusion is most of the time this is treated as a foreign body in our spine, and if we can get you through 3 months of the discomfort, most of the time the body will resorb this, it'll go away forever, okay?
What will the body do?
The body goes in there and attacks it almost like a foreign body and it resorbs it, it gobbles it up. Because you do an MRI 6 months, 12 months later and it's gone.
And it's perfectly round.
Well, I mean, this
Yeah.
this little piece here is gone. Yeah. And then a sequestration is when it kind of breaks off and it travels up or down. Okay. So these are all the different varying degrees of disc problem. Now, when somebody comes in and they say, oh, doc, I have pain in my back and down my leg. Well, each nerve goes to a different area of your leg. So when somebody has an MRI and it shows a disc problem on the right at the L3 level and they have pain down the back of their left leg, well, that MRI, that disc at the right on the L3 isn't causing your left leg pain because the nerve at that area doesn't go down your leg, okay? So we have these things called dermatomes. So essentially, the dermatome is the distribution of the nerve in your leg. So each nerve, and we're looking at the majority of the population, some people are wired differently, but most aren't, show that the different nerves go down different parts of your leg. So the L3 nerve usually goes into the thigh to about the inside of the knee. The L4 nerve goes usually into the front of the shin and it stops at the ankle. L5 goes all the way down into the foot, to the top of the foot, into the toe. And usually the S1 goes down the back of the leg into the calf, into the bottom of the foot. So that's how we kind of distinguish between these different areas. And also, you know, if we're doing targeted injections, we want to know where we want to put that needle to give you the best chance of success rate. So really that mapping of your pain is important for us to treat you, okay? Now, diagnostic testing. So these are all the tests that we use to diagnose you, okay? Most of the time, people don't need diagnostic testing for about a month because most of the time we can do conservative treatment. As long as you don't have any of those red flags I talked about earlier, you're not in severe debilitating pain, that we need to do something to get you feeling better quickly. You don't have any weakness or numbness in your leg, we usually can be conservative for about a month before we have to do anything more aggressive, okay? Now, if you have a trauma or something, we do anatomic x-rays, okay? So this is to rule out fracture. CAT scan isn't really routinely done anymore for the spine because it's not as good as an MRI. MRIs are pretty readily available. The only time we ever really get CT anymore is post-surgical patients or people that can't get MRIs because of pacemakers, metal in their body, or some other reason that doesn't allow them to get an MRI, okay? Most of the time, though, when we get a CAT scan and we really want good pictures, we do what's called a myelogram, which is where you put a spinal needle into the spinal fluid, you inject contrast dye, and you take the CAT scan with the contrast dye. That gives us the best picture, okay? So that's what the myelogram is, and it's usually combined with the CT. And then the bone scan, usually that's for more like ruling out infection or cancer, okay? That's not routine, or a fracture, I'm sorry. A fracture as well, we can use a bone scan. Now, there's physiological testing. Well, what is a physiological test? Essentially, it shows the function of the part of the body. Really, the only thing that we have available to show function is nerve testing. So when people have these interesting exams, they don't have something really compressive on the MRI. Well, what's causing that nerve pain? Well, we look at nerve testing to really figure that out. And that's called an EMG, a nerve conduction study. I'm sure a lot of people have heard of EMGs or have had them done before. They're not the most pleasant tests, a lot of electric shocks and needles, but you know, sometimes it's necessary to help us really treat you properly. Diagnostic procedures. Most of the time, diagnostic procedures for sciatica are really only used for surgical planning. So a discogram is disc pain that's causing the pain, and it's really used for surgeons to help with fusion planning. And diagnostic blocks I use to make sure that there's not another structure that's mimicking sciatica so that we're not misdiagnosing it. And then laboratory testing is usually to rule out rheumatological conditions that also could be mimicking sciatica. Lyme's disease is another one that can sometimes mimic sciatica. So that's what we use lab testing, is when we don't have a clear etiology for your pain. Now, what are the different causes for sciatica? Well, there's mechanical and non-mechanical pain. Mechanical pain is any type of structure that is being squeezed by a part of the body. So mechanical pain is when a disc is herniated and it's pressing on your nerve root. That's mechanical pain. There's physical compression. The other theory behind sciatica and why that nerve is so inflamed and angry and causing pain down the leg is it's inflammatory. The disc ruptures, it releases all these inflammatory markers into the region where you have that nerve root, and the nerve gets inflamed and it gets irritated and causes sciatica. So those are the two different theories. I mean, if you ever cut yourself and you see that big red ring around your cut, same thing happens in your spine, and your nerve is right next to where that disc is herniated. So all that red inflammation that you feel on your skin when you cut yourself is going on in your back, okay? Now, neuroforaminal stenosis with nerve root compression is usually more of an arthritic problem where the nerve root gets really narrowed and you're in certain positions, and that narrowing causes the nerve to get compressed and causes pain to go down the leg, okay? Spinal stenosis we've talked about in the past, where the spinal canal gets narrowed. Standing and walking usually aggravates the pain. Some people can't sleep at night or lie flat. They have to kind of sleep in a recliner. That's how bad the stenosis pain can be. Now, non-mechanical spinal pain, these are the things that cancer, infection, or sometimes rheumatological conditions that causes inflammation of the nerve roots or other structures of the spine that causes radicular symptoms. So let's talk about treatment a little bit. So the majority of the time, I like to try conservative treatment. So what is conservative treatment? It's anything that's non-invasive, in my opinion. Non-invasive treatment is rest, ice, heat, whichever feels better for you, okay?
One's not better than the other? Cold, hot?
No, not really. Whichever feels better. Sometimes we'll say 2 to 3 days of ice, but then heat or ice, really whatever feels better. To be honest with you, it's just helping the muscle spasms in the back. It's never penetrating all the way down to where that nerve is. It never gets that deep. Then we talk about all the different medicines we have. Anti-inflammatories, the stronger pain medicines, the opioids like Percocet and codeine and the hydrocodones that people take. Antidepressants sometimes can be used for nerve pain. The anticonvulsants, most people have heard of Lyrica or have at least seen it on the commercials. There's another sister medicine called gabapentin. They were originally designed for seizures. They're not really used for seizures much anymore. They've been kind of transitioned to pain medicines because they're more effective for it. And really, we use it for nerve-related pain, or fibromyalgia is another indication, but we're not talking about that today. Topical indications, and then some people get steroids, prednisone, Medrol dose pack. You get a very potent anti-inflammatory effect from these medications, but they do have their side effects as well. Then other treatments that can be done, physical therapy, Sometimes people go to chiropractors, some people try acupuncture. Alternative treatments are relaxation techniques, biofeedback, all the psychological type of treatment that people try to do, mind over body techniques. And then the spinal manipulation is either osteopathic manipulative medicine or chiropractic, okay? Any questions on the non-invasive treatments? No? All right, so minimally invasive treatment, that's kind of where I take over a lot of times because people usually come to me with most conservative things done already. Well, these are the pain management treatments that everybody talks about. Epidural injections. Sometimes the sacroiliac joint, which is a pelvic joint, can send pain down the back of the leg. Mimics sciatica. That can also be done under x-ray guidance. And trigger point injections are more just for the muscle pain in your back. Okay, that can be done to help relieve those muscle spasms. So these are really the minimally invasive treatment options available for you. Then the final option, if the pain is unrelenting, you have weakness in your leg, you have bowel or bladder incontinence, you have to go see a surgeon at that point. And if you have an indication, a discectomy is essentially when they go in, they just take out that little piece of disc that's irritating the nerve, and there's not too much other surgery done. They're just taking that piece of disc that herniated out, and that's it. It's minimally invasive, a small incision. They use these instruments to keep it, as minimally invasive as possible, almost like when they scope your knee, except it's not a camera. They actually visualize it directly. So the recovery time is quick. Decompression, that's usually used for more of the spinal stenosis, where you have to decompress the spine, taking all that arthritis out to open up the spinal canal again. Sometimes when people have a decompression, they also need a fusion. So what a fusion is when they put bone in to essentially fuse two bones in the spine together, and sometimes they'll put screws and a plate in to make sure that area is solid while the bone is incorporating and becoming solid. Disc replacement, not done in America anymore. The disc replacement's done about 10 years ago. 90% of them or something failed and got taken off the market. They are still being done, I think, experimentally in the trial phase in the neck, but they're not available for the lumbar spine, okay? So I think if you need a disc replacement in your low back, you gotta go to Europe. And then spinal cord stimulator essentially is a pain management device that we use when people have failed all of the above treatment options and they're still having that nerve pain down their leg. Because unfortunately, when your nerve gets injured, 100% of people don't recover from it. So people are stuck with chronic nerve pain in their leg and they want something done about it. Spinal cord stimulator is something that I actually do a trial where I put a lead into your spine. We put an electrical signal over the back of your spinal cord and essentially it blocks your pain from reaching your brain. And then if it works, I send you to a neurosurgeon to get it permanently implanted. It's almost like a pacemaker type of apparatus that gets implanted into your spine, okay? So that's something that's more used for chronic pain, not for acute pain, okay? So in conclusion, most episodes of this sciatica will resolve eventually. So don't think that you're doomed if you have an episode of this. What you can do to prevent this is stay active out of bed and try to not aggravate your pain. Avoid activities that aggravate your pain when you have episodes like this. You're going to get better eventually, we hope, okay? If you have any of those red flags that we talked about, and it doesn't result with the conservative treatment that you're started on, come in to see a specialist and we'll see what we can do for you. Maintain an active, healthy lifestyle, and if you're a smoker, please stop smoking, okay? Any questions?
What's your theory on medical marijuana?
Medical marijuana is an amazing...
If they, digest it.
Right.
Yeah.
Medical marijuana is actually a very effective treatment option for nerve-related pain. It is. So I strongly believe that people that suffer with chronic nerve-related pain, medical marijuana would be a great treatment option for them.
It's like I'm a disabled veteran, and to get the VA to approve anything like that is very difficult.
Yeah, I agree.
Yeah.
It's hard to find someone in New Jersey right now. It's really strict still. People have to have a special license, and it's sometimes difficult in certain states to get the medical marijuana.
Yeah.
Yes?
2 questions. One about the medical marijuana. Perhaps I should know this. They talk about it on TV. Is there medical marijuana that doesn't zone you out?
Yes.
Okay.
Yeah. they
And
really
in fact, that is what the medical marijuana is, isn't it? The one that you're not spaced out.
correct. You don't get the other side effects that you do. It's very concentrated, and there's actual different type of chemicals and concentrations of the different chemicals in different formulations for different conditions.
And regarding the smoking, I'm just asking this for a friend. The smoking the smoking problem. Is that because it affects circulation?
That's what we think. Yeah.
Because
So
there's so many other reasons to stop smoking
we just
but-
look at this at the population, and if you compare the population at the same age between non-smokers and smokers, smokers have much more degeneration in their spine than non-smokers. Yeah.
Drug Dilaudin.
Yes.
I was just in the ER last week with it, and they gave that to me, and all of a sudden I felt terrific.
Mm-hmm.
So, is my spine fine, or is that like hiding pain that might come back?
Well, I mean,
When I
Dilaudid
was
is,
released in 3 or 4 hours, I felt terrific, but
and then when it wore off, did it come back?
not yet. Knock
Oh,
on wood.
knock on
but
wood, right?
I'm very afraid. I'm scared of it coming back again.
Well, I mean, it very
So where
well.
does that fit in drugs? I mean, like,
Well, Dilaudid is hydromorphone, which is an opioid. Okay, so it's a controlled substance. You need a prescription from a physician to get it. You can only get it 1 month at a time, and then you need another prescription written for it. So it is a controlled
but
substance.
it takes it away just like that.
Well, I mean, it's in the same family as the Percocet and Vicodin and codeine, and it's all the same drug. It's just
It doesn't mean I'm necessarily fixed, healed, or anything. See, I'm not too sure with that drug. Is it just masking the symptoms? Do I still have an injury?
well, if you're not having pain right now, whatever's going on there isn't causing pain anymore. But what happened is the medicine took you out of that pain cycle and maybe allowed your body to
Oh, okay.
get out of that pain cycle so that you were able to get more functional,
Yeah.
and therefore the pain goes away. So that's what we try to do. We try to control the pain so that you can become functional. Your body heals itself. Even though you have arthritis in your spine, you can live with arthritis in your spine, and it can be non-painful.
We have a question online. Now.
Sure.
Doreen, what would be a treatment for piriformis syndrome?
So piriformis syndrome, essentially piriformis syndrome is a muscle in your buttock. And essentially what it happens in a certain percentage of the population, and this is through cadaver studies, the sciatic nerve pierces directly through the muscle. So these are the people that we think are prone to having sciatica secondary to that nerve being irritated by the muscle itself. So that's really what we think the etiology of piriformis syndrome is. So treatment options for piriformis syndrome initially is physical therapy, stretching, medications. Then followed by that, either you could do a ultrasound or a fluoroscopic guided injection, either corticosteroid, and then usually the final thing that works for most people is usually Botox injections into the piriformis muscle.
Thank you.
I'll take this.
Could you discuss where tramadol fits into the?
Yeah, tramadol is kind of one of those in-between drugs. It's recently gotten escalated to more of an opioid, but it's not really a strong opioid medication like Percocet, Vicodin, and those medicines. It does have an addictive potential, but it's not I don't think it's a very strongly addictive drug. So it works on multiple receptors in your body. It works on the opioid receptor, which is a pain receptor in your brain, but it also works on some of the serotonin and norepinephrine receptors in your brain as well. So it's different than the opioid. It's kind of in its class by itself.
How about
Lyrica is one of those nerve pain agents, and it's actually originally was designed to be a seizure medicine, but it's not. It's used for nerve pain at this point most of the time, or fibromyalgia is another indication. Yes.
Is it called gabapentin? That's
Gabapentin.
Neurontin.
Neurontin, yeah.
Yeah. Now, what are the I tried it, and one day of my life it just obliterated.
Mm-hmm.
Took 100 milligram pill, and the doctor did prescribe, 3 days with 100 mil, 3 more days with 200.
Mm-hmm.
Gradually working. I couldn't. Now, was I not giving it I don't mean to be too personal, but what are the statistics or what usually happens? Another doctor in another field told me it is a very good drug to work with pain, but you have to give it a chance to get used to. But can a person function a normal life and do their exercise and yoga and Pilates and things that they want to do and take that and do people usually get used to it?
Yes and no. I mean, somebody like you who took 100 milligrams and you were knocked out for a day, you're extremely sensitive. I doubt you would have become tolerant to those side effects. Okay? You just can't walk around like a zombie for 2 weeks to try to get used to it. So I think if you double the dose, it would just happen again and again and again. So there is a certain percentage of the people that don't tolerate the drug. Okay? That's just a fact of life. Not everybody tolerates these medicines. The number one side effect I find in most of my patients who don't tolerate it is cognitive issues and sleepiness from the drug. I usually start my gabapentin medications at nighttime because of that. I usually don't do it. So if you have a hangover and you're still sleeping from it during the day, you're very sensitive, and I highly doubt you would have tolerated it long term.
I'm wondering if it interacts with certain blood pressure meds.
It doesn't. The only thing it really interacts with is other medicines that cause drowsiness. Other than side effects, it's an extremely safe medication. The same thing goes for Lyrica. Most common side effects on those medicines: sleepiness, difficulty with your memory, difficulty focusing, blurry vision, and swelling. People call it swelling in the legs. Those are the 5 most common things I hear from most of my patients. There's many other side effects that you can read about, but those are the top 5, I'd say.
And another med I became familiar with in Italy because I got the Italian version when I was walking around there, and in pain, and I have it with me. Begins with a V, but I think the American version is the Flector patch. That's an anti-inflammatory.
Yes.
Is that correct?
Yeah. The medicine's called diclofenac.
Yeah.
And it comes in pill form, it comes in patch, and it also comes with an IV or an IM injection.
Okay. Is it a big deal to get the patch approved?
It can be. Yeah, it needs to be pre-authorized sometimes, depending on your formulary.
Okay, and that's an anti-inflammatory. Is that a good thing to use for sciatica? To put it down here?
Maybe.
Maybe.
I don't know about putting it on the low back because really the root of the issue is the nerve being irritated. That medicine never penetrates that deep.
That's what I'm wondering.
Most of the time it's better for like elbow problems, knee problems, something that's more on the surface. 15% of the anti-inflammatory still gets absorbed into your blood system. So if you have kidney problems, if you have a problem with your GI tract from anti-inflammatories, if you have a really high risk factors for cardiovascular disease, you'd want to clear it with your doctor first. And most of the time, people that ever had an ulcer from anti-inflammatories in the past or people that have kidney problems, I don't prescribe the patch because 15% will still get absorbed through the skin into your blood system.
But if something like naproxen, that's an anti-inflammatory,
It is.
right?
It is.
If that helps, would the Flector patch?
Again, I mean, the anti-inflammatory ingested is more systemic in your blood system.
I see.
Higher levels in the blood system. The Flector patch is more topical, local, so
It might not get absorbed.
it might not get absorbed or deep enough, or enough of the medication might not get absorbed to cause that systemic effect of the anti-inflammatory. Most of the time with the epidurals, we're putting that steroid, that anti-inflammatory, right where that nerve is being inflamed. You know, we're going a couple inches deep, depending on your anatomy, to put that medicine where it needs to be.
I've also heard, this is layman's talk, that some injections can cause degeneration of the bone. Is that incorrect?
Well, degeneration, steroid injections, if you do too many in a given amount of time, can cause weakening of the tissue in that area, the ligaments, the joints, those kind of things. Most of the time in our practice, we only do about three epidurals a year per body region to limit those kind of risks to you. Yeah. Yes, sir.
Thank you.
And you started off your lecture very interesting by saying only 1% of the pain is associated with the sciatica nerve problem.
Correct.
Why do they call all these things sciatic?
It's because it's just one of those old terms that we can't get rid of. It's just it's an old school medical term that is just commonly used. And the one thing that causes the sciatic nerve, piriformis, causes compression of the sciatic nerve, or a tumor growing in the sciatic nerve. Those are the two things that really cause nerve pain just from the sciatic nerve.
I went to a pain management doctor who was also a physical medicine doctor because I had pain down in here in
In the ankle.
the outside of the foot. And he said, well, it could be a sciatica problem. I got the impression from him that it's coming from the sciatica nerve.
Right.
The sciatica nerve does go down there. So was he incorrect by saying that, or?
No, he wasn't incorrect. He was just using the common term that most people know. If he said I think it's coming from a lumbar radiculopathy, most people look at you like you have two heads and they don't know what you're talking about. So yeah, I usually say, it's probably a disc in your back that's irritating a nerve. People more commonly know it as sciatica.
What nerve is it irritating if it's that?
It depends. I mean, that's what the MRI helps us discern. Yeah. I mean, if it's going down into the outside of the foot, it's usually the L5 or the S1 nerve root. Okay? Yes?
So I had a couple of questions about the piriformis syndrome. How do they diagnose that?
Usually it's a diagnosis of exclusion. And also
I'm sorry, of what?
of exclusion,
Mhm.
meaning that you rule out other things that are more common because it's uncommon. And sometimes you can send somebody to a special radiologist that will use an ultrasound machine, and he can actually see the sciatica nerve being split through the piriformis.
And
Or
where would the pain be with that?
It would be down usually the back of the leg,
Okay.
into the calf or the front of the down into the front of the leg into the foot.
Does it always go down that far?
Not always. Not always. And there's certain things on examination that you can kind of stretch the piriformis and it can reproduce your pain, direct palpation.
Mm-hmm.
You know, there's the examination findings that help us kind of point us in that direction.
Dr. Young, we have a follow-up on two actual follow-ups. Doreen was asking, she is actually coming to see us for piriformis this week. She's a 35-year-old mother of two young children, and she is struggling, and she wants to know if that injection for piriformis is usually given on the first visit. She has all of her chiropractic treatments, oral steroids, and a stretching program. So is it the kind of thing that you would get on her first visit?
Usually not, because it needs to be set up for a separate appointment when you have the x-ray guidance.
Mm-hmm.
Okay, so you need that x-ray guidance, and most of the time we have to dictate a note and submit it to the insurance company to approve some of these procedures. So most of the time the initial evaluation is that. It's an evaluation, seeing if we agree with the diagnosis and making sure it's not something else and that we're treating you appropriately.
Okay. And then Ann asked, can a sciatic nerve block that is done to help with post-operative pain management damage the sciatic nerve?
If they directly inject medicine into the nerve, yes, it can damage it. Yeah, and usually we can tell that on nerve testing. There's certain findings on the nerve testing that show injury to the nerve. Yes.
Question, you said you might be able to damage the sciatic nerve by a different injection? Because I went to like a wellness holistic and they did injections of their type in that area. But it was fine before I went there, and after that it wasn't. So you think you could,
No.
you hit that sciatic nerve with a needle?
Oh, absolutely. Absolutely. Yeah, if you hit the nerve directly with the needle, you can cause nerve damage from the needle by direct trauma. Or when people get regional blocks from anesthesia, like they do a sciatic nerve block for surgery, and that needle is in the nerve and they inject the medicine into the nerve, and it causes, the pressure inside the nerve root causes destruction of the nerve.
Is that nerve in real far?
I'm sorry?
Is that nerve pretty deep in your?
Yeah, it is.
Okay,
It is.
so
It is. I mean, there's been sciatic nerve damage from injections in the buttocks for vaccinations and things like that. It happens. It happens. Yeah. Yes, sir.
There is the EMG procedure fall in the diagnosis of those?
Well, the EMG helps us. EMG would help us classify what's causing the nerve pain. Okay, if we can't, let's say we can't figure it out on an. You come in with numbness in your leg. You come in with weakness of your leg. We do an MRI. There's nothing compressing it. Well, what's causing this problem? That's where the nerve testing helps us diagnose you. Any other questions at home?
Nope.
Any other questions in the audience?
Doreen and Ann both thank you. That was a big help.
Thank you. All right, thank you guys. Thanks for coming out. Go clean up the trees.
We need you to write prescriptions for that medical marijuana.
I don't have that license.
These cards up here, if anyone wants to take one on your way
Oh,
out,
that's
this
funny.
is a direct scheduling line for us. If anyone was interested in scheduling with Dr. Young or any of our other physicians.
Do you get a machine or do you get a person when you want it?
A live person during business hours.
If you go to emergency care rather than hospital, they give you that long?
Most of the time, though.
I mean, you have it to give it, or they?
No.